All right, we've reached the final panel of our event. This is the Primary Care Innovation Showcase featuring technology and digital health. I'd like to introduce our moderator, Sara Pastoor from Elation, and she'll introduce the rest of the group.
Hi, can you hear me? Yes. Okay, great. Thanks so much for being here today. I'm really excited to get into this really rich topic about technology and what we need from technology to support high-value primary care, the primary care of the future. And so I'm Sara Pastoor. I'm a family physician. I'm an unapologetic primary care evangelist, and I always love coming to events like this to be around like-minded people. You guys really inspire me, so it's great to be here with all of you. And so I work for Elation Health, and Elation is a technology company that is focused on primary care. We have an EHR that is purpose-built for primary care. And so I think a lot about technology and primary care, and I also continue to practice clinically part-time in the San Antonio and Austin area. And so I'm also acutely aware of what technology is not doing for me. And so I've been involved in health technology for about 13 years now, mostly because I'm a loudmouth about what we need from technology to take better care of patients. And I think we need technology. I look forward to the day when technology is working for us instead of us doing battle with it or it falling short of our needs. So I'm so excited for the opportunity today to introduce you to this really distinguished panel. We have Dr. Subha Airan-Javia, we have Edwin Miller, and we have Adam Gail. And their bios are in your program. But I think this is going to be a great conversation about what we need to get data and information into the hands of PCPs, and how we can connect care longitudinally and across settings, and what are the barriers. So we're just gonna get right into it, and I'll start by asking each of you to tell us a little bit about your background in health technology and also what you're working on now. Subha, you want to start?
Sure. Hello. Can you hear me okay? There we go. All right. Well, thank you so much for having me here today. I'm very excited to talk to you all. I would say, instead of calling you a loudmouth, I would say a fierce patient advocate who expects only the best so you can take great care of patients, which really is what technology should be able to do for us. So I am Subha. I am a hospitalist in Philadelphia. I practice at Penn Medicine, where I've been for the last 15 years. I'm also an informaticist. I used to be an associate chief medical informatics officer for Penn Medicine. I am now CEO of CareAlign, which is a spin-out of Penn Medicine. And actually, my whole love for technology in medicine started as an intern when I realized that we don't have the right tools to help us work well together. So that really launched me into a career in informatics and working in the space of designing and developing tech to make it easier for us to do our jobs. So did that for about 15 years before spinning out this company. As you, I still practice medicine part-time, but otherwise I'm doing the entrepreneurship thing full-time. And I would say that my mission and what I'm working on now is still really in line with what I've been doing over the last 15 years, which is my goal is to make it easier for us as clinical teams to do the right thing for patients. And too often our systems, our processes, our technology make it hard to do the right thing. And so because of that, we find necessary workarounds. And if I were to put an angle on what piece of that we're working on right now, it's really about what I like to call an information supply chain problem, where in medicine, it's really hard to have the right information to the right person at the right time in the right format so that we can make decisions for patients. Sometimes we have too much information, like in the EHR. Oftentimes there's way too much information to find what we need. Sometimes we don't have enough, like when our patients are seeing other providers and we have no idea what happened. And sometimes it's in the wrong format, scattered across 30 different places, and I can't find what I need when I need it. So that's really our goal, is to help make it easier for us to find what we need and work better together around patients.
Hi, I'm Edwin Miller. I'm currently at Google Health. I've been in healthcare technology for 30-something years. I'm not a physician, but I've had the privilege of working alongside care teams trying to build this stuff. And I go back to, I've worked on maybe 4 EHRs, led the development of them. I started out as a developer, moved into more product management kind of things, and have seen, I remember when people were really excited about EHRs and saw the potential of them. I've seen the whole arc of the optimism around that to the sort of jaded attitudes that we see now towards them, and I guess I've moved up the stack from twiddling bits, as it were, in technology to thinking about different technology models, to thinking about different business models, to thinking about different care delivery models. I was one of the co-founders of Aledade, which was all about championing primary care in value-based care and really helping primary care physicians capture the value that they create by kind of doing the thing that they want to do anyway in terms of practicing, and increasing their share of the value that they create. And so kind of moving up the stack there. Now I'm at Google, where we're probably moving back down the stack in terms of technology. But the thing that we're working on now is around really solving some of this sense-making problem of there's so much data but very little insight, a lot of noise, and not much information, and of course, the advent of AI and large language models and how that can be applied to healthcare is kind of, and I don't have all the answers on that, but that's kind of what we're focused on at the moment.
Hi, I'm Adam. Like 25 years ago when I was in college, I majored in broadcast journalism, and I remember there was a class on like where to look in situations like this, where you're in a room with live people and cameras, and I'm trying to remember what the right thing is to do. It's not coming back to me right this moment. I work for Stellar Health. I probably have a little bit of a unique point of view from everyone else. I'm clearly not a clinician, and I'm certainly in awe of those that are, and that's why I'm in this line of work. But my job is to take these technology solutions to market. And so I actually get to see almost daily the struggles that offices have with the technology that they're using or that they've been asked to use. The challenges with some of the design of the technology, and it's kind of led me to where I am today. I've been in digital health for about 15 years. About 10 years in, I decided I really wanted to focus on primary care. I think it's the future, kind of like the hub of all the spokes of the healthcare ecosystem, and one of the most challenging places. I just feel it's like completely underserved from a technology perspective. So focused my career on there. I've been doing some things in virtual specialty care, but now with Stellar, we're really trying to help these clinicians and their offices honestly succeed in their kind of evolution to value-based care. It's very challenging. The contracts are confusing. The incentives are sometimes misaligned. The rewards for succeeding in the models are like way out in the future and sometimes extremely nebulous. So incenting and making sure that they are empowered to succeed in these models is important. And that's where we spend a lot of our time, is getting them the right information through technology at the point of care, but then also rewarding clinicians, which they are so challenged from a time perspective to perform these actions, which can take away from other things that are basically revenue generating for them. So spend a lot of time on those granular incentives, rewarding the staff and the clinicians for the things that they're going to do to drive these outcomes that ultimately benefit the patients, and making sure that I guess that they feel like they're part of the process, right? So that's very important to our company and very important to me as well.
That's awesome. And so on that note, we know that primary care is facing an existential crisis of burnout and administrative and documentation burden. And at Elation, we have studied this quite a bit and even looked at it by delivery models and payment models. And what we're seeing is that value-based models actually do decrease burnout and burden. However, the documentation burden specifically and the administrative burden actually go up. So the stress is lower, but you've got even more of that other stuff. And so I'm wondering from each of you what your thoughts are on what technology can and should be doing to relieve some of that burden and give clinical time back to the PCP.
I have a lot of thoughts. So I think it's really fascinating data. When we think about what leads to burnout, it's obviously multifactorial. And so hearing that it reduces with value-based care models to me really reflects that we find joy in helping patients, right? And value-based care is all about achieving the goals that you want. And so when you're working towards that, it feels much more rewarding, which is great. The documentation piece increasing, I was initially surprised because I hadn't heard that stat before. But I actually think it makes a lot of sense because all of our processes and all of our technologies are designed around an encounter-based system and a fee-for-service system where we act like, we have these intermittent, static, episodic interactions with patients and forget about the in-betweens. Whereas in value-based care, it's really about how do we, as a team, work together to take care of a patient across an entire continuum, regardless of where they are. And we really don't have the right tools to make that easy to do. So I think that's part of what's contributing to the documentation burden. I think that, one of the things we have to do, we can't replace our EHRs, no one's asking to do that, but what we can do is, and I guess in some cases you can, but what we do need to do is, I think, leverage technologies that build off of the foundations that we've put into place with our EHRs that are specifically designed for these new and emerging workflows. So specifically what I mean is, documentation that's iterative, documentation that's collaborative, documentation that's structured around what is the work I've already done without having to write things 2, 3, 4 times. So a lot of the work we do is around, as a team, we're constantly writing things, and by we I mean, clinicians. We're constantly writing things on to-do lists and emails and in-basket messages. We're faxing things to each other, and then we're writing that information all over again in our documentation and for different compliance purposes. Why not use well-designed technology to pull what we need out of the work we're already doing, out of the communication we're already doing, to then meet that documentation need? So I think it's not a flip of the switch, but it's really a different way of thinking about, like you said, making the technology work for us instead of constantly trying to fit what we do around the existing technologies.
So burnout's interesting. So my comments don't reflect my employer. These are my own thoughts, just to be clear. I think, at Aledade, we used to think a lot about one of the key causes of burnout is actually the moral injury caused by the system. And so to the extent that maybe value-based care makes things better, it's probably because it relieves some of that. We live in a system that will spend any amount of money to treat the stroke, but spend no money to manage the hypertension that 5 years ago that maybe led to chronic disease. And so we're all trying to move upstream, be more at the top of the waterfall, catching patients before they fall down into the bottom of the waterfall where the whole healthcare industry lives and makes money. And so we have these conflicts where, so I think a lot of burnout has a lot of root cause there. And I think on the tech side, a lot of the additional data capture and things like for quality measures and stuff, I think those were envisioned to actually be automated, but they haven't been. And so just to pick one, the other one's RAF, which is super annoying to everybody. So the first year that we spent hundreds, millions of dollars to wire EHRs into an LHR and then try to capture quality measure data the first time, we got 11%. So that meant 89% had to be done with chart reviews when we did our first CMS reporting period. It was, and after we had spent all that money and time, and we had some pretty smart people working on it. So, it got better. But tuning even the systems that you have to do the work it adds more work. And then RAF is something that tends to be clinical, or it has to reduce to, you can still automate away a lot of the suggestions and suspect codes and all that stuff, but at the end of the day, a clinical person has to make the decision about what to code. And I think that adds work and more thought. The way that we address that to some extent was to really link raft to actually good patient care and think about things that you don't normally code or that you might be missing, or things that you don't want to code, like depression and obesity and stuff like that, that has weight, so to speak, on the coding side. And but there's no great answer to that. But I think the other thing is that I used to see, and I saw this at Sitka, where we were doing virtual consults between specialists and primary care, was the primary care expands the scope. Value-based care expands the scope of PCPs, but that's just, they don't. There's a counter trend against pushing back against all of that extra scope, and where do they really want to take on that additional, care management and things like that.
It's funny, Edwin and I learned that we've basically followed the exact same career path for the last 15 years, working in the same pieces of the healthcare world. So I look forward to working at Google in about 5 years. At Stellar we have about 7,000 PCPs that are using our tools, and so we get to spend a lot of time in the offices. And I go to the doctor once a year, and but spending a whole day in there, it's incredible what you see, and the stress and the precision that's necessary and the collaboration between everybody in the office. And so I think about burnout. I think not just about the PCPs. There are incredible burnout statistics about the staff members in the office as well. And as more and more is asked of the PCP, there is more and more that needs to be more and more collaboration and responsibility that goes to the staff. And they participate in no way in like value-based incentives or anything like that, but we're asking them to do more and more. So where we spend a lot of time with our technology is building something that allows all the people in the office to do the right things for the patient in the timely way, to make sure that we are raising kind of the right actions at the right time. But I think the true power is the real-time incentive model, saying like, we will pay you for your time to do this, right? To do the right thing, we will reward you. So many of the offices are sharing those value-based incentives that we're pulling forward with the clinical staff. And keeping them excited and motivated to help with these things has been honestly magical. The stress that it takes away from the primary care physician to know that the support staff is motivated and is happy to do the things that they're doing. When an office is short-staffed, it is awful for the PCP to try to fill in those gaps, and patient care suffers. And we have just seen like the support staff prior to Stellar going into a number of these places just leaving the healthcare industry in droves because of larger wage increases in some other areas of the economy where they can work. So I think you have to look at the whole entire office when you look at what technology does and what incentive models do to drive them towards value-based care, and we've seen that be incredibly effective.
So hard to have a conversation about primary care success without also talking about payment and compensation and workforce, and it's all connected. Yeah.
I was about to say that this is almost pie in the sky, but I can't be part of this panel and not say that there's a real problem in our healthcare industry when the people who are, as you said, the hub of the hub and spoke model are getting reimbursed and compensated the least. And when we think about incentives, whether they're monetary or anything, they tell you what you care about, or at least what the people who are giving the incentives care about. And what that tells a lot of people is that that's not what's most important. The most important thing is doing the neurosurgery or the IR procedure to fix the stroke as it happens. But, we need a real change in how we value our primary care system, because without that, we can't improve our health statistics as a country, which are amongst the poorest in the world.
Well, amen to that.
The original sin of healthcare, I think, is fee for service. That's what we live in, and it's like water. It's like the joke about the two fish swimming along, and another fish goes by and says, "How's the water?" And one of the other fish goes to the other and says, "What's water?" And they don't even know that's what they do all day, every day. It is so.
That is such a good analogy.
It's such a firmly ingrained in our site. Our EHRs are built around it. So our EHRs are, I hate to say it, they're episodic, they're billing based, they're a lot of the pain comes from the fact that they're not holistic and longitudinal. We don't think upstream. Fee-for-service medicine is deterministic, to use a computer term, meaning that you see a patient, you bill some things, you get paid. It's pretty easy. Value-based care is non-deterministic, it's almost stochastic, like meaning that you're doing something now and you may not see the value. What's the value of not having pneumonia 8 years from now for administering a vaccine today? So you don't really know. There's a lot of uncertainty between now and when the value will be realized, and so this means that to measure this stuff is really hard, and so it becomes more of an analytics problem, actuarial problem, that kind of thing. And so, but moving upstream requires data to become more predictive and thinking upstream than getting paid to think upstream. And so I think PCPs naturally will try to move upstream, but the industry holds us back from that. And so there's this tension between the calling. We have a calling to do what we do, and I say this as a non-doctor but I'm there with you. And then we have the industry, which is how we get paid and that we work in, which is very much about dollars and cents. And those two things are pretty much all inherently in conflict.
So we're all stuck in Stockholm syndrome, is that what you're saying?
You don't even know it. How's the water?
Yep. Well, so, I mean, we can't solve payment today, but
Yet.
well, there's emerging models, right? And so that's
Yes,
what we're all part of. That's what Stellar is helping bring that. The problem is it takes 18 months to know how you did, and the first ACO that we ran, we lowered inpatient admissions, inpatient utilization, reduced ED utilization. We did all the right things, and we lost money because it's a very resilient system that we work in. That responds. It creates antibodies to anybody trying to reduce, because one person's revenue is another person's waste, and so we're all trying to remove waste, but there's another person whose bonus is based on that thing, and so these inherent conflicts are we're dealing with a business model change that we're kind of in the middle of.
Man, we could talk about that for another hour. So in these alternative payment models where we're more focused on value, I want to talk about what you think primary care in those models needs the most from technology today. We know that technology in most industries advances pretty quickly, but not so much with EHRs. And so we've got some, shiny new objects out there, remote patient monitoring and wearables and AI, things like that. Are those the things that are going to solve our problems, or what do we need?
So I think we kind of got to blow up the EHRs, and no offense. I think that, and I say this as someone who's built some of them, and I don't even tell doctors that anymore, especially if they have a sharp object in their hand when I'm in their office. And so I think it starts with you have to be LHR first, meaning longitudinal health record, which means being very greedy about getting data from all the other places, and that's happening. And the first step of the EHR was kind of replace a paper chart, right? It was a substitution. And it's all very siloed in one clinic or something like that, or one database. And so now we start to have national networks, HIEs, things like that, where we can pull data and share data better. And but it's still hard to make sense of that data. And so there's an LHR, which is just bring the data in, and then there's a sort of a normalization sense-making layer that has to happen at scale. And I have thoughts about why this isn't happening, but anything from just linking the data together, normalizing it to some ontology, to then actually which data is important and who needs the right information at the right time. And then once you have that, then you can start to build workflow tools on top of that. So I've already described probably 10 startups that would need to be funded by, there's no VC that I'm aware of that's willing to fund all of that in one, and you probably don't want it all in one place. And so it's more about how the platforms emerge, and we've just not done that as an industry. We've built VC-based, EHR companies that are proprietary and tend to think about things in a protected way. And I'll stop there.
You said so many things that I like, starting with the first one. But ending with what you, or I'm going to start with what you ended with, which is we have this industry that wants returns in 2 to 3 years, right? Or maybe 3 to 5 years. And it takes longer than that to change the processes. And when I think about, the HIMSS exhibit floor where there's football fields worth of new things, everyone wants this shiny new object to be this, patch to fix this one tiny piece of a problem. And in fact, one of the things I hear most often from people is you're trying to do too much, and if you're trying to sell something, it needs to be one tiny piece. It's like, well, that's not enough. You need to be able to go to the root cause of an issue and address the underlying problems or the underlying cause of so many multiple problems. So I think there needs to be a lot of different things, but one of them is apply these new technologies, but not to say, let's fix this one surface problem, but perhaps take the 5 whys principle of quality improvement and say, what is the cause of that problem? What's the cause of that problem? What's the cause of that problem? And address the underlying issues. And I'll give an example, which is the in-basket or messaging. There is such an overload of messaging everywhere, whether it's inpatient, outpatient, and it's not just your EHR messaging, it's also the text messaging that we have. We're actually doing research on how many text messages clinicians get. The preview to this unpublished data is, at least on the inpatient side, frontline clinicians on a 12-hour shift are getting texted every 2 to 4 minutes all day. And I mean, imagine, and the reason why I started doing this research was because I was trying to tell a patient that she had cancer and that it did not look good. And in the process of trying to tell her this awful diagnosis, I was interrupted every 2 minutes. And it's a secure message. So it's not like I can just look at my phone notifications and triage it and say, oh, I don't need to address that request to order Tylenol right now. It's a secure message. You have to unlock your phone and interrupt, and it's a really awful experience. But when you consider your secure messaging and your in-basket messaging, there's so many things happening. I've probably heard 10 different people in just the last week say, oh, AI is going to fix our messaging problem. It'll respond to all of our messages for us.
Now you have more messages.
Right. How about we change why we have so many messages in the first place? How about we not send a message every 2 minutes or send it to 10 people? So many of our messages are actually tasks. They're actually saying, hey, what's the status of this task? There's no concept of what I think of as a project management or team management solution in medicine to say, as a team, whether I'm the primary care doctor, the social worker, the community health worker, the inpatient doctor, the consultant, let's have a shared view of, for any given patient, who needs to do what, when, why, where, and what's the current status. It's not enough for it to be buried in 50 different progress notes. It needs to be easy to see, easy to work on, and to be real-time and iterative.
Is CareAlign going to do that for us?
It already does.
Because I would love that.
Yes, but we need to have a change in how we think about things. And I think you're going to get to this of how we make it easier to adopt new technology. But those are the kinds of things that I think we need to change. So I could name 10 things that primary care physicians need, prior auth being high on the list of getting rid of. But,
Just banish it entirely.
Yes, completely. But my soapbox otherwise is making it easy for us to work as a team, even when we're apart.
You spoke about like the HIMSS floor and that's how innovation seems to be brought to kind of our world. And I think it's really curious how it comes to pass, how it's designed when you look at it through the lens of a primary care physician. Because from what I've seen, it starts with, well, here's a problem we need to solve, right? And so let's solve this problem and let's do it in a way that we can drive better patient outcomes. And so that's the premise of bringing the solution to market. So next is, well, how do we get it paid for? How do we show that it proves value? How does it return investment when someone were to implement it? And you put that whole package together, and then you're like, well, how do we get the doctors to use it? And that's half of the innovation, is asking that question at the end. How do we get the doctors to use it? Well, you should have started there, is the answer to that question. And I think that's what excites me so much about what we've been doing at Stellar. We basically started with an activation platform that rewards and that physicians love. And then let's figure out what we can do with that, right? So like starting with something that makes them feel special and something that aids them in a way, instead of kind of ending there, which is, I think, what happens with most solutions. And that's when you see the fatigue, right? Like you mentioned, there's point solutions for every single little thing. And they all sound great in a vacuum. But when put into practice, there's just simply no way there can be that many different point solutions addressing that many different problems. It's just increasingly overwhelming for the PCPs and their staff. So when I look at technology, you should start with the user. You should start with the person that spends the most time with that technology, and they should get the most benefit from it, right? Everything else flows down. The PCPs want to do more for their patients. They want to spend more time with their patients, but they can't, right? I mean, in the value-based care models, in those advanced primary, models where it's the Oak Streets of the world, yes, they can, right? Because the model is different. But there are so many primary care physicians and clinics, the vast majority, that are like stuck in the middle of this fee-for-service and value-based care world. And they have to keep the lights on. And they have to make sure their staff is taken care of. So they don't have the time to do these other things and say, I hope I get paid in 18 months. So how do you align those incentives, and how do you do it with technology that makes it easy for them to do it? So, I think we have to think in reverse in some ways when we bring this innovation and technology to these clinics and to these doctors. We need to start with them instead of not ending with them.
Yeah, this issue of these niche solutions comes up a lot for me as well. And what we don't want to do is create even more friction at the point of care, where you have fragmented workflows because of multiple systems that don't talk to each other, and then you also feel like you have to double document, and then you're squirreling away data and information in different places, and they might not necessarily be the same information. It might, conflict, and it costs more money, et cetera. So I'm so interested to know from all of you. I mean, obviously the EHR cannot be and do everything, and there are a core set of capabilities that you need from an EHR, but then you also want to be able to have the flexibility to sort of customize your tech stack to meet the needs of your practice and your patient population. So what should be native to the EHR, and what should be in an integrated partner solution to create a seamless workflow so that I don't feel like I'm having to...
at Allada, you said doctors just ask me, just tell me what I need to do. I just want to come in, and I think I think of it, to maybe have a glib answer to your question, zooming out and looking across all the patients, your panel, your flock, what's the highest value thing I could do today for this group of people? It's not necessarily my schedule, which is the patients who are coming in. That's more reactive, but it's more proactive around making sure the right patients are on the schedule in the first place, and again, getting upstream and thinking about that, and then having the right data 360 that you need to do the work, and again, having it not be so noisy that you have to wade through and waste your time, or swivel between different applications and things like that. So I think that's a tall order, but that's what I hear.
I have a slightly different angle, and I'd say I don't think we can define what should or shouldn't be in an EHR or not. I think that changes. And I think you'll get 50 different responses from a lot of different people. If you take a moment and think about your phone, right? Your phone has like 50, if not more, different pieces of technology on it, which all work seamlessly together. And we've all probably used 10 of them every day between our calendar and email and text and WhatsApp and at least 5 other things, right? But our experience is that it's seamless, and we don't even think of it as having to go into all these different applications because they just work. Technology should be able to do that for us, and I so often hear people say, oh, well, how do we get doctors to use it? How do we get them to do the right thing? How do we manage the fact that they hate technology? I have news for everybody. Doctors love tech. We love gadgets. We love things as long as they work well and they help us take care of patients. So, but what you'll find is a lot of IT departments, because of the security and the privacy and the compliance regulations, hate introducing new things, and they don't want to make it easy for things to connect. So I think for us to really build a tech stack, which I do think is what we need, a tech stack that works for our teams of clinician and staff, we need to make it easier for things to actually work together. We need to streamline the process of doing security reviews for new technology so that it's not, recreating the wheel every time. And we have to have people whose job is to say, how do I make sure that the user, from the doctor to the staff, are having a seamless experience going from one to the other. I think tied up in that question also is what is the legal record versus what is in the EHR versus what is outside of it. And a lot of times what I hear is, oh, well, if anything is written anywhere, it needs to end up in the EHR. I don't believe that that's true. And I think that that's especially in our very our medical legal environment, people think that if you write a word about a patient anywhere, it has to be part of the legal record. And the reality is medicine is not an exact science. It takes us time to get to what we actually want to put down in a chart as what we think about patients and what we think about a plan. And we need the space to be able to do that without saying every single thing has to end up in the chart. Last piece I'll say is on this topic is we did research. We published a study last June in JAMA on how much data is in notes, in charts. We're doing a follow-up on including vitals and labs, but just words written in notes in charts. We looked at 7 years of data at Penn, over 100 million notes. Ended up being 190 billion characters in this electronic health record. So what does that mean? All of English Wikipedia in all time, at the time that we wrote this paper, was 24 billion characters. So that means that in one health system, in 1 year, we generate more text than what we as a race, as a species, have put into all of Wikipedia. And when you break it down to the patient level, each individual patient chart has about 5,000 words. That's at the median. That's about 1/5 of Hamlet. So if you have 10 patients in a day, you're technically responsible for the amount of text that's in 2 copies of Hamlet. And 50% of it is duplicated from a different note, but you don't know which half. So you're now making life and death decisions off of 2 copies of Hamlet. You don't know which half is copied from the other half. It's often out of order, and you actually have no dedicated time to read it.
Yeah, so the bloat. I go back a long time, back when handwritten notes were relatively brief and they were unstructured data, right? And then EMRs came along and said, we really want to measure this stuff, and so we need to structure the data. And so now, and we force clinicians to structure the data into the system by putting a bunch of boxes on a screen and clicky click. And now, actually, with AI, now one of the big jobs of AI is taking unstructured data and turning it into structure with a machine. And so one of the most powerful uses of this will be summarization and bringing the right information to bear. But it's just interesting how I think a lot of that's just bloat. I mean, what you're saying. I mean, it's duplication of data. It's charting by exception, where you have a bunch of normals and a bunch of noise in the chart, and the real information that you need is actually a very small subset. But what is that subset?
Well, and knowing what's the right information, right? If you have an algorithm, how do you know what is the right signal? The reason why I started that study was because I had a patient who had HCC written everywhere. So we thought he had hepatocellular carcinoma. Well, he was admitted for something totally different, not a long admission. So I said, as we were preparing for discharge, let's make sure that the loop is closed on his HCC, that he's hooked up with GI, and all of that's taken care of. Can't find anything about HCC. It's like, oh, I guess it's never been treated. We spent an hour digging through the chart, and it turned out that HCC came from a code, which had an HCC code on it, that someone copied and pasted into another chart, and then it got copied everywhere in his chart.
Say it isn't so.
It's 100% true. And you can't even get rid of it. It's like a virus, right? I can't even get rid of that. I can write in my note, this person does not have HCC, but there's...
And then it finds HCC.
Right, and if you had an algorithm look at it, it'd be like, oh, well, HCC is written like 1,000 times in this chart. This person must have it.
Yeah, we did a lot of this sense making, and making it medically tuned and understanding the context, and it's a very hard problem. The language models are getting pretty good, scary good at this. Yeah.
You mentioned kind of that your phone being the epicenter of your world from a technology perspective. And if you think about like how value-based care is constructed, it's not just one clinician's office, one PCP. They're part of large affiliated networks, clinically integrated networks. And the decisions on what technology is going to be used to practice value-based care is not being made by the doctor. So imagine if like something just showed up on your phone. Yeah. And like, this is how you're going to text from now on.
Or they gave you your phone.
And you were like, well, I don't know. Or they were like, hey, we took away your other way to text, but test this way to text for about 30 days and tell me if you like it. And then that happens over and over and over again. And so, trying to think about how to integrate with EHRs if you have great technology in a clinically integrated network where there's 17 different EHRs amongst the 200 practices that are participating in that value-based care model. And each one of those practices is participating in 3 or 4 different arrangements with different groups. It's incredible how difficult it is. So I think we spend a lot of time trying to focus on making something that is like agnostic to the model. Although we have places where we are integrated with the EHR and places where we are not integrated with the EHR, I think if you focus on kind of like making it a wonderful experience for the clinicians and having them participate meaningfully in the offices in the actions that they're doing, we've seen incredible success in that. But it's so daunting to think of like the way that so much of this technology is just pushed down. And I think it behooves us as an industry to involve the primary care physicians more in the design of some of these tools and more in the decision making on whether they should be implemented by these larger kind of value-based organizations.
Well, we have another intractable conflict between the people who buy tools or not the people who use tools.
Correct.
You took
100%.
that out of my mouth. That's exactly right.
And
That's
The
right.
economic buyer is not the user
Yeah.
of these systems.
Yeah.
And it creates a huge tension and problem.
So we have some policymakers and policy influencers in the audience, and I'd love to hear from you. Obviously we have a lot of barriers to getting the right technology and the right information into the hands of the people who need it to make sound clinical decisions. But if you could ask policymakers to do something, what would you ask them to do?
I'd ask them to spend a day in a primary care office. I really would.
Yeah.
It was life-changing for me. And so, like I said, I think everyone has experienced going and spending their 1 hour getting their annual wellness visit or, their vaccine or something. But I would encourage them to spend one day from 9 to 5 sitting there shadowing not just the doctor, but maybe some of the support staff and see what that is like. And I think that would change a lot of minds on how some of this stuff has to be
It
implemented.
would. Yeah, I've spent many such days, not as many as people in this room, but I always used to say, if you have a bad day at work, go visit a practice and be highly motivated to help. I think that I think the policy things are happening. They're just happening too slowly. Like moving to value-based care, changing the business models, the incentives, the things that they're reducing administrative burden. There's a CMMI program right now to try to. It turns out that ambulances, in order to get paid, they have to drop a patient off at a hospital, and so there's a CMMI program where they're testing. What if we just send them to urgent care, or what if we send them to a lower acuity? It's just there's all these buried, misaligned incentives and things that are happening, and I know that I feel like those things are happening, but it needs to happen faster and more. I'll just maybe chime in a little bit on the AI stuff. The AI is happening super fast, and it's spider cracking into a lot of smaller things. So we have Microsoft doing ChatGPT, Google's doing Bard. There's big companies doing it, but there's also open source things happening that are happening much faster than those companies. And trust me, there are companies that are trying to make a doctor. And so the governance of this and how it works needs to be dealt with. And so I would say, policy is going to move slowly. It's going to move way slower than the innovation will happen. And there's there's going to be a bleeding edge probably. But I would just say that's the area that needs to be focused at. But it needs to be pretty informed, and be a little more conservative than what's happening.
Those are two really good answers. I have to add to yours to also spend a day in the hospital.
Sure.
Following people in the hospital, because it's all part of the ecosystem. Geez, after they visit people, maybe also hold their phone for all of their text messages that they have to answer and be in charge of their inbox and fax machine. But I was going to say this is nebulous, but make it easier for people to try new technology, and that's really centered around the HIPAA policies that really hinder a lot of new technology usage and experimentation. Doesn't mean to change the quality with which we keep things secure, but the policies really have become such a hindrance to be able to try new things. And perhaps a subgroup to that, when I think of the Cures Act, I was very excited about the information blocking rules, but it's all from the patient perspective. So an individual patient can say, hey, you can't block me from having access to my data, but it's not from the provider perspective. So if we could have like a version of the Cures Act which says you cannot information block data that a provider wants to be able to access to get data about their patients, that would open up so many doors, because there's a lot of CIOs who information block all the time to their providers.
100%. We fought that all the time. Plus one to that.
Great answers. I think we're out of time, but I do just want to pause and see if there's any question in the audience. Do you have a mic, Ken?
Hello. Hi, Kenneth. I'm still a direct primary care doctor. But this is actually more with some of the work that I explore at xprimarycare.com. So you guys touched on a lot of the points I was going to ask about, but it seems like there's some parallel play, right? That's a milestone where kids will play next to each other, but they won't play with each other in the health tech community versus like the primary care community. Being at this gathering, listening to people talk about tech, it sounds similar but vastly different from some of the conversations that happen at like HLTH or Vive, where they talk about primary care, but it's also very different. And so how do you see the two communities, I guess, playing together? Like what can we do to bridge the communities so that they don't keep playing next to each other, but they play together? And also, as the pendulum swings from more hospital consolidation to supporting independent practices like what Alade's doing, do you see more opportunity for integration of tech in independent practices rather than hospital systems?
So I think creating I hate to say this, creating awareness with the IT community around the role of primary care and its sort of growing influence, for lack of a better word. They're not caught up. If you ask the average, I struggle with this in companies where the first thing they think of is hospitals and large, organizations and payers, and because primary care accounts for I don't know what the number is now, 5% of total spend, but it influences 80-something%, but it's lost on most casual observers in the industry. So I think forming those relationships like AFP and we used to work closely with them at Alade. At Alade, we're dealing with what I call the post-EHR world, which is, okay, you got the EHR, great, but now we have to do all this other stuff to use the data to actually treat, manage patients differently. And so we built a whole data layer or a whole tech layer to do that. But what worked there is not going to work at Oak Street or somewhere else. Every organization that's doing this at scale has variability in different pillars of what they're doing. And this is what makes it hard, I think, for one vendor to come in and just, build something for everybody, at least right now. So, but I think, so I don't know if I've answered your question, but I think it's creating awareness and around the sort of quarterback role that happens in primary care, that everyone understands who's in it, but outside of it, I think there's an awareness problem, I guess I would say.
So the last two organizations I've worked for have served primary care. The best innovation that we've brought to them was because we had a primary care clinician in the room when we were designing it. Yeah. And I think that doesn't happen often enough. We think we know what primary care would want or use, and then ask after the fact. Involve primary care clinicians in the design of the solutions. I think that brings them a lot closer. There's a feeling of involvement, engagement. There's a sense of ownership then, and we've built elegant and useful things in that way, and I'd like to see more of that.
Yeah, I think what you're describing is some of what you touched on, which is that's like building from the outside in, from the company down, versus this is more the group, I don't want to say up or down, but this is the group actually, on the front lines. And I think part of what we're seeing is a lack of financial incentive. So it's 5% of the spend, and 80% of the work. And then even when you do work in value-based care, it's not the people on the front line that are really driving that revenue. It's the people who are, managing the MSO or the value-based care organization. So, I think ideally having a financial incentive to actually improve primary care and have them drive decisions would help a lot. But absolutely, as someone who did build Inside Out from, literally as an intern, you have to have a melding of these two groups to actually have more successful innovation.
I love how you guys are describing Elation Health. Thanks. So thank you so much. What a pleasure and a privilege it has been to absorb your expertise and your brilliance. And I just cannot thank you enough for coming and doing this with us. And I'm telling you, that whole Hamlet thing, I was like, just drop your mic. That was enough. All right. Well, thank you so much, everyone. And yeah.
Thanks for having us.
Good
This was
conference.
great.
Thank you.
All right. What a fantastic panel. Thank you all. So I get the opportunity to reflect briefly on these past 2 days as a health services researcher and a clinician and a primary care doctor. And I want to sort of sum up what we've been thinking about. We all know, and we've talked a lot about, how primary care is the foundation of the healthcare system in the US and internationally. We know from a lot of really good evidence that primary care is associated with better outcomes, including better care quality, better patient experience, lower use of ED visits and hospitalizations, reduced spending, including spending on low-value care, and even reduced mortality. Yet, research by my team and others has found that there's been a decline over the past decade or so, and even longer, in primary care visits, which are the building blocks of primary care and the relationships between patients and clinicians historically. So we've looked into why that is, and the findings that it's really multifactorial, right? We have some issues with access to care. We have barriers, both financial in terms of paying for visits. We have capacity constraints. We heard a lot about the maldistribution and inadequacies in the primary care workforce. We've heard about other kinds of barriers, like decreased perceived demand for primary care, or people, especially younger adults, maybe not seeing the need for a continuous primary care provider, but also some maybe positive or neutral shifts that explain this decline in visits, including changes in how we practice. We know from evidence that visits on average are longer. They're packed with more stuff. We're doing more preventive care, talking about more diagnoses during these visits. And there's also shifts to alternative settings and sites of care, and also different ways that we interact with patients beyond that in-office visit. So these trends are concerning. They do speak to the broader worries that we have about the sustainability of primary care despite its importance. And they also suggest ways we can strengthen primary care and its 4 core functions. That's the first contact access to care, coordination of care, continuity of care, as well as comprehensive care, which really underpins the value of primary care and what it can offer. So we've had a chance to dig into some of these solutions over the past few days, and I want to just highlight them briefly here. So the first idea is to make it easier to go to visits, right? To both book them and attend them. That's this idea of reducing the friction of going to visits. That could be through technology like direct scheduling, where patients can book their own visits online, making it easier through transportation services to get to those visits. We heard about things like on-site employee clinics that just create more convenience for patients to get where they need to go. That also means expanding the definition of visits, right? So we've all been using a lot of virtual care, and that should include phone and video visits, as well as secure messaging, while ensuring that we have the capacity and the funding for clinicians to be able to offer those services and the flexibility to make that happen. The next idea is to leverage primary care teams, and we can define that in so many different ways. We heard about the sort of traditional primary care teams, including the role of staff and medical assistants, those who are working at the front desk, nurses, nurse practitioners, and physician assistant colleagues. We can work together to work at top of our licenses to provide good care to patients. That also means expanding the definition, thinking about our behavioral health colleagues, working closely with social workers workers and psychiatrists, for example, embedded in primary care practices. That might mean working with colleagues to think about social determinants of health and how to take care of that for our patients, and community partnerships. We also learned a lot about investing in communities that have not historically had good access to primary care. And I'll just name some of the many excellent groups that are starting to think about this and described it in our sessions in the past 2 days, including Oak Street, Main Street Health, Unity Healthcare, Urban Health Plan, and Asian Health Services. Really reaching out to specific communities, building trust in those communities, and thinking really holistically and broadly about what they need beyond the traditional offerings of primary care. The next idea, and this really, I think undergirds so much of what we've talked about, is designing primary care payment to provide clinicians with the infrastructure and flexibility that's needed to provide good primary care. And by that, so many examples I can touch on, but I'll mention, CMS really advocating for these advanced primary care models that offer predictable prospective payments so that we're not guessing at how much money we have to take care of patients, and thinking about moving away most broadly from fee-for-service medicine, which is still the predominant way that primary care clinicians are paid, towards these value-based models that we've been hearing a lot more about. And, for example, also paying clinicians by panel size or using direct primary care as payment mechanisms that allow that flexibility. And finally, we want to ensure that we have the workforce to care for these patients, and that includes so many different steps along the pathway from the beginning. So exposing future clinicians to the joys of primary care, and really investing in people who will stay in their communities, tackling the hidden and explicit criteria, or curricula rather, in training, in medical school and residency and beyond, that really discourages future clinicians from practicing primary care. Improving the experience of learning primary care and training in primary care, for example, in residency, so we can, don't give the residents essentially these really rushed experiences where they don't get to experience the joys. And finally, retaining people in primary care. This is so critical, and thinking not just about, or rather focusing on structural solutions to burnout, for example, like through technology, as we heard about in the last panel, as opposed to individual. Like, we don't need more yoga classes. We really need to focus on making it more of a joy and more easier to take good care of patients. So taken together, there's so much we can do collectively to improve or to really realize the full potential of primary care, and to make sure that value is clear to stakeholders, to the public. So this has been a wonderful opportunity to come together on these issues. I want to thank Primary Care for America and all of our participants today for participating and for inviting me to join. Thank you so much.